Of this new year's Ethics Grand Rounds, sponsored by the University of Colorado Hospital Ethics Committee and the Center for Bioethics and Humanities. I'm Jackie Glover, a philosopher ethicist that does consultation. I'm on the consultation team, both at Children's and at the U. And I'm very pleased to introduce our speaker for this start off of the new year. I'm my friend and colleague, Dr. Brian Jackson, who is going to be talking about the ethical issues of treating minors, pediatric patients, children in adult hospital. Children come through our ED. They, in addition to our NICU, they come through our ED with mental health issues, with trauma. They even deliver babies. And so it's with really anticipation, I'm going to introduce Dr. Brian Jackson. And if you have questions or comments, please put them in the chat and we will monitor the chat and allow for a lot of time for questions at the end. Dr. Jackson, take it away.
Thank you. Let me just share my screen here. Perfect, great. So yeah, thank you for that introduction. I have no disclosures to make. What I'd like to do today, I'm going to go through an outline of what I'll say here in just a minute, but just to keep the big picture in mind, my objectives for today's talk are to compare the ethical frameworks that exist for providing medical care to three really distinct groups, at least in my view: children/neonates, adolescents, and adults. And I think all of those groups have a little bit different framework for how we think about approaching their medical care. Second, I want to describe some of the differences that exist between how the legal system might approach some of these questions and how an ethicist might approach some of these questions as we talk about how to provide medical care for children. And third, I want to identify some resources that might be able to assist adult-focused healthcare team members who also provide care to children and adolescents. So I'll put some of those in at the end, and I'll probably mention some as we go through. So to do that, I'm going to talk about several distinct things. First, I'm going to talk about infants and young children, or my just say no group, because I think we've all experienced a toddler who just says no, 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 no. The second thing I'm going to talk about are older children and adolescents who are able to communicate with us and who often have the attitude of "you can't make me." I'm going to talk about parental authority and its limits. I'm going to talk about some special confidentiality considerations that apply when talking about adolescents. Because Dr. Glover introduced me, I felt the need to include a section on justice. A lot of those issues are similar to the issues adult hospitals face, but I wanted to make sure that we talked about them. And then finally, like I said, I'll conclude with some resources that might be helpful if you do take care of children. Before I get into it, I do want to just make a quick disclaimer. I am a pediatrician, and over at Children's, we have this policy that no adults are allowed unless accompanied by children. We, I think, have many of the same issues caring for adults that folks who are primarily focused on caring for adults have when caring for children. So if you'd like to see the other side of the coin, we're planning a pediatric ethics grand rounds later this year over on the children's side to talk about caring for adults in a pediatric institution. So please consider coming to that as well. So let's talk first about infants and young children. So I'd like to start by kind of focusing this a little bit on a case. And I'm going to start the case with something you all are probably familiar with, which is a 65-year-old woman's admitted to the ICU with acute respiratory distress syndrome secondary to influenza pneumonia. She's intubated and sedated. The ICU team is thinking about whether to start hemodialysis for her. She is not able to participate in her own decision-making at this time. And so I think that's a situation that probably arises fairly regularly at University Hospital. And I think when you talk about how to approach that question, I don't think many people have a ton of questions. If the patient has a medical durable power of attorney, an MDPOA, you'd ask that person to make a decision based on what the patient had previously told them. If they don't, you'd gather the interested parties, attempt to appoint a decision maker, and again, make decisions based on what that patient would have wanted if she were still able to communicate her preferences. Pretty straightforward. I don't think there'd be a lot of questions in that circumstance unless there was difficulty finding a person who could represent, or there was disagreement among those people about what she would have wanted. But in any case, the ethical framework for making those decisions, I think, would be pretty transparent. So let's make the case a little bit different. And now instead of a 65-year-old woman, it's a 2-year-old child who's admitted to the ICU with acute respiratory distress syndrome from influenza, is also intubated and sedated, and we're also considering dialysis. Now, how do you make the decision? I think this is the challenge of caring for those pediatric patients. When you're caring for those pediatric patients, they haven't often had the ability to express their preferences, express their values in the same way that an adult patient likely has throughout the course of their life. And so that's really what this first part of the talk is focused on, is for those neonates and young children, how do we figure out what they would have wanted if they were able to speak for themselves? Certainly one option is to have a very philosophical baby and to take that baby's preferences into account. But since most of us don't speak baby, I think that we have to come up with some other standard. We know that infants and young children are not able to consistently express their values and preferences apart from no, don't look in my ears. Because of that, we don't think of them as moral agents, as people who are able to make decisions that have moral weight on their own. And they really need somebody to make those decisions for them. And who do we have make those decisions? Parents. So parents are usually the folks that we have as surrogate decision makers. They're the people who likely have the best understanding of the likely future values and preferences of the child. So a lot of people ask, well, why are parents the ones who are able to make decisions for their children? Why is it not somebody else? Why is it not the doctor who understands the medicine the best? Or why is it not the state, the county or the state who can make decisions for those children because they can make sure that that child's interests are protected? And the reason for that really comes from two places. The first is that parents are likely to have the best understanding of the future values and preferences of their child. So they're the ones who are starting to inculcate those values into their children. And as such, they probably have the most say over what those values will be as that child matures and is able to express their values for themselves. That's not to say they'll be perfectly concordant. They probably won't. I think we all know many teenagers and adults whose values are quite discordant from their parents, but they have the best understanding of any values their child has been able to consistently express and what values are trying to instill that are perhaps more likely than average to show up in that child. The second reason is practicality, right? So somebody has to choose for these patients somebody has to make decisions for these pediatric patients. That person could be the state, but it's really hard in a pluralistic society like ours to say that the state can really make the same decision for children across the board when we do have so many unique ways of raising children that we consider socially acceptable. And so again, the people who are most invested in that child and who are closest to the situation are generally speaking the parents, and therefore we let the parents make the decision. So that's really the undergirding of where parental authority is coming from. But how do parents make that decision? What kind of decision-making standard do they use? We know that in adult patients, we like to use substituted judgment, right? What would the adult patient say if the adult patient were here with us, if the adult patient were able to express her own values? How would she want to be treated in this circumstance and with the medical information that we have? That doesn't work for neonates, right? The baby is not able to tell us, I would prefer to have extended painful treatment in order to extend my life, or I would prefer to have less painful treatments, even knowing the risk that has a risk of shortening my life. So we have to use some other standard. We can't use substituted judgment. There's a variety of standards that are out there for limiting parental authority, which I'll talk about a little bit later. But in general, the decision-making standard that we want the parents to be using to make decisions is best interest. So what's in the best interest of this child? I think even the people who suggest limits on parental authority agree that they want parents to make decisions that are in the best interest of the child, that's the framework they should be using when they think about what do I do in this circumstance? What is best for the child? There is some discussion that perhaps the well-being of the family as a whole could also be considered. So children are necessarily born into families, right? They have parents, they may have siblings, they may have other family members whose views can be considered or can be taken into account as those parents make a decision for the child. And so there is some discussion, at least, that maybe the child by themselves is not the only thing that should be taken into consideration. If we go back to our 2-year-old patient with ARDS, how would we approach the decision making about whether to start dialysis or not? Well, we'd likely go to the parents. The parents are the people who have the authority to make that decision based on the reasons that we've discussed. And we'd ask them to use the best interest standard. So to say, if your child, if a average child or if a child with the values that you're trying to inculcate in your child were able to make a decision, what would they decide? And I think most parents in this circumstance would likely choose dialysis, but not all would. And we'll talk a little bit later about when decisions go outside of the scope of parental authority, when decisions are made that are clearly not in the best interest of the child or that cause harm to the child, and how we might limit that decision in just a few minutes. But in general, we'd ask the parents to make the decision, and we'd ask them, if they say, how do I decide, to make that decision based on what they think is in their baby's best interest. What about older children and adolescents? So what's different about older children and adolescents? So older children and adolescents are generally able to express their own preferences. They are able to express some degree of values. They are able to express some degree of treatment preferences. And that ability varies a lot. And it varies based on a lot of factors. Some of them are certainly age and maturity. Right? So as people get older, they're better able to process information, have abstract reasoning, and apply their values to the practical situation that's in front of them. That's affected by a lot of other things. So that can be affected by life experience. Right? So a patient who has been in the hospital for most of their life will have a very different understanding of what decisions, what the consequences of their decisions are, and what their preferences might be, and how to apply their values to a particular clinical decision than a patient who this is really their first significant experience with the healthcare system. So that can absolutely make a difference. Individual variation is also extreme within this age group. So people, I think we've all experienced, mature at different rates, have different cognitive increases at different rates. And because of that, different children and adolescents, even of the same age and with the same experiences, may have quite different ability to process information and apply their values to that situation. So I think one of the key take-homes from this older children and adolescent section is that there's a lot of variability. And it really does require an individual assessment of how each patient processes information and applies that knowledge to their decision making. Because of that ability to express preferences and values, when we get into this age group, we talk much more about assent in addition to consent. So as a quick review, consent is usually the legal authorization for a procedure. So who is legally authorized to make the decision? In most cases, I'll talk about some exceptions on the next slide, but in most cases, for most medical treatments, that's still the parents. So the parents for a minor are still the ones who are legally authorized to make decisions for a patient, and therefore they're the ones who give legal consent. Assent is agreement that does not necessarily contain legal weight. So the older child or adolescent would be able to say, I agree, or I dissent, I disagree to the treatment that's being proposed, even if that statement does not necessarily carry legal weight. It does carry moral weight and ethical weight as we're weighing the decision-making for these patients. The second point that we've talked about previously is that these children have developed some levels of value and judgment, but that's highly variable. But I think the third point on this slide is actually another really important one, which is that the seriousness of the decision matters. So I often tell people, I have a 5-year-old at home, and we routinely let her choose which arm to get her vaccination in. When she gets her flu vaccine this year, she can choose if she gets it in her left arm or her right arm. She does not get to choose whether she gets the flu vaccine or not, because that's a more serious decision. And that same type of framework applies to children and adolescents throughout the spectrum. So as the consequences of the decision become more severe, the relative weight of the minor's viewpoint versus the parent's viewpoint will change. So for minor decisions, i.e. which arm to get your vaccine in, or which arm to place an IV in, or whether to take Tylenol for pain or not, the child or adolescent's weight will likely carry more voice. For more significant decisions that may be life-threatening or limb-threatening or have other serious consequences, the adolescent's relative weight in that decision may be less. And so the relative severity of the consequences of the decision definitely matters as we're deciding how much weight to give that adolescent's voice. Minor consent laws vary significantly between states. So if you're practicing somewhere other than Colorado, I'd encourage you to look at your own state's laws and policies regarding consent for various procedures. These are all specific to Colorado. For those of you who do practice in Colorado, the Colorado Association for School-Based Healthcare actually has a great resource for what things minors can consent to on their own and which things require parental permission. So that's where a lot of this information comes from. The state legislature also has pretty good research papers actually on this that are available on their website. So minors in Colorado can consent to all care if they are 15 plus, living alone and financially independent, if they are married, and they can consent for their own children's care, which does create some interesting circumstances where a 16-year-old mother may be able to consent for her child's medical care, but cannot actually consent for her own medical care for routine medical needs. And that is something that we encounter at children's with some regularity. For specific treatments, minors can consent to treatment for pregnancy. They can consent to treatment for contraception, except permanent sterilization, which is specifically called out in the law. So that is not further defined, but in general, that would include things like a hysterectomy, an oophorectomy, a salpingectomy, and a vasectomy. Any of those would be things that the parent would actually have to consent for, and there would have to be some additional legal safeguards in place. Minors can consent to abortion in Colorado. Parents are required to be notified, but are not required to consent to the procedure. Post-sexual assault care is actually specifically called out as something that minors can consent to. Sexually transmitted infection testing and treatment, minors can consent to. Substance abuse treatment, minors can consent to. And mental health care if they are age 12 plus. That was recently changed. It used to be 15 plus, and it's now been dropped. The age for consent has now been dropped to 12 and over. So for any of those areas, the minor can actually consent for themselves. For most of those, the law is actually silent about whether that treatment can be disclosed to the parents. Most institutions have particular procedures and policies about under what circumstances these minor consent diagnostics or treatments can be disclosed to parents. So that is, if the healthcare provider says, I think the parent should know about this, can the provider disclose to the parent over the objection of the child? The only thing that's specifically called out in law is if a minor discloses that they are at imminent risk for suicide, that actually has to be disclosed to parents. So that actually is in the law, but nothing else on this list has a specific call out in Colorado law. Again, this varies by state, so if you're somewhere else, please look at your own state's minor consent rules. This is my most busy slide in the entire presentation, so I'm sorry about it. But the reason that I like this is that I think it does a nice job of demonstrating how children develop capacity and how adults, at least sometimes, lose capacity as they become elderly, and they may develop cognitive disabilities related to advanced age. So the red bar on the top really represents children's development over time. So they start with legal incapacity. Parental authority is the really key ethical principle at stake, with the safeguards including best interest, assent of the child, and the right of the child to be heard and to have their views at least considered. They gradually gain capacity over time until they reach the capacity level of an adult. It's important to note that on the right side of this graph, where they have legal capacity after the second vertical black line, they may not have developed their full capacity as a 30-year-old adult, but they have enough capacity that they are legally considered eligible to make their own decisions and ethically considered eligible to make their own decisions. The blue line represents adults on the bottom and shows basically the opposite. So you can almost put that blue line adjacent to the red line. So as adults develop various cognitive disabilities, they slowly lose capacity to make their own decisions. And they have some of the same and some different safeguards in place. So their preferences should still be considered, especially their preferences given while they still had capacity. Assent and dissent to procedures, advanced directives, and involvement in decision making. Unlike in children, where parents are assumed to be the correct decision maker for a child, for adults, it's their legally authorized representative, whether that's somebody who was previously appointed by an MDPOA, or whether that's a legally authorized representative appointed through the proxy law. I think this is a nice, I think for adult focused providers, this sometimes makes it a little bit easier to think about children as adults in reverse. they have start with less capacity and gradually gain it as they get older. This is probably the area where there is the most conflict between law and ethics in this age group, in these older children and adolescents. So older children and adolescents may well have the medical decision-making capacity, so the ethical standard that we'd use to make their own decisions about a variety of medical conditions. So it would not be at all uncommon for a 17-year-old to have the same assessed decision-making capacity as an 18-year-old. And ethics would treat those people as ethically the same. If you have the same medical decision-making capacity, the same ability to have developed values, apply those values to a situation, understand medical information and its consequences, then you should have the same ability to make decisions. The law, however, would treat those people as different. The law would say that until you are 18, that is a clear, bright line where you are able to make decisions for yourself, barring other cognitive disabilities. That 17-year-old would not have the ability to make decisions for themselves. And so this is a place where ethics might say that 17-year-olds should be allowed to consent to treatment, should be allowed to make their own decisions about what treatments come next. The 18-year-old also should be allowed that. The law would say the 17-year-old should not be allowed, but the 18-year-old should be allowed. So this can lead to a conflict that often requires intervention from an ethics team or from other supports within the healthcare system to help talk families through both the ethical framework for looking at this as well as the legal framework. Next area I'm going to talk about is parental authority. We talked about where that authority comes from, but we haven't really talked about what limits it. So when are times when parental authority is not absolute and the decision should really be taken away from the parents? Jody Picoult, of all people, actually said that traditionally parents make decisions for a child because presumably they're looking out for their best interests. But if they're blinded by the best interest of another one of their children, the system breaks down. I'm not sure that's entirely true, but I do think that there are times when there can be conflicts between children. We'll talk about that as we go through this section. I actually really like this graphic. This is taken from a provincial equivalent of a Department of Human Services, Child Protective Services in Australia. And it just gives an idea of the broad categories of things that go into determining a child's best interest. So things like the need to protect the child from harm, the nature of the child's relationship with families, the child's actual views, child's need for permanency, child's age, gender, sexuality, cultural, ethnic, religious background, physical, emotional, intellectual, spiritual, developmental needs. So lots and lots of things are going into determining what's in the child's best interest. And it's really hard for one person to actually take all of this holistically and say this one thing is in the child's best interest. At the same time, we want people to do their best to act in what would be the child's best interest to maximize all of these various goods. But you can see that when there are this many different goods, you might have different parents that say, well, the blue box is more important for my child, and the brown box is more important for your child, and the red box is more important for a third child. And you might have a difficulty determining what's truly best for each child or for an average child. That's the first critique of best interest, is what is truly best? Is there really one approach that you can take that says this is the best approach to making healthcare decisions for this child? And if you take this approach, you will make the right decision. The second critique is that what if there's more than one child in that family? What if there are two children and their needs conflict? So it's in the best interest of my two children for me to go to child number one's drama show and child number two's flute recital, right? How do I decide which one to go to using the best interest standard? I can't, right? Because I have to make decisions in the best interest of each of those children, and doing so conflicts. So you're putting a parent in an impossible situation where there is no right answer. You could see how that could also apply in the setting of healthcare. You know, it might be best for a child who is chronically ill to have a parent at their bedside in the hospital 24 hours a day, but they also have a child at home who it would be best for the parent to be with that child as well. And how do you balance those needs using the best interest standard becomes really difficult. So that's where this idea of what's overall best for the family might be something that you'd consider. That's been a response to that. And what about minor decisions, right? So I do things all the time that are not in the best interest of my child, right? Like it would be in the best interest of my child to read to them from the moment I got home until we eat dinner and then read some more. But that's not what we do. Right? We do other things and we have other competing values and priorities. And I don't spend every minute of my day at home with my children. And that's okay, but it's probably not in their best interest. So should I be removed as their decision maker? Probably not, but what justifies that? So there's a couple other standards that come into play that I'll talk about. The first is the harm principle. So this actually derives from work of the philosopher John Stuart Mill from a couple centuries ago. The only purpose for which power can be rightfully exercised over any member of a civilized community against his will is to prevent harm to others. And so the harm principle really focuses on what is harmful to the child. So this is best described by a pediatrician up in Washington named Doug Diekema. And he applied this to medical care and says, well, yes, parents should act in their child's best interest, but the state is really only justified in intervening on those parents if there's actual harm to the child. And he created this list of 8 criteria you might think about as you're deciding whether the child is actually at significant risk of harm. So first, is there significant risk of serious harm? Is the harm imminent and requires immediate action to prevent it? Is the intervention that would prevent it necessary to prevent the harm? Is the intervention proven to be effective to prevent the harm? Does the intervention that's been refused not also place the child at significant risk of harm? So if that intervention is something that could be considered equally harmful, then you don't really have a justification to intervene. Is this the least possibly invasive option that you have? Is there some other option that would also prevent the harm that's more concordant with the parent's wishes? Could the intervention be generalized across all similar situations? And would most parents agree that the state intervention was reasonable if it were publicized? So if this were in the newspaper tomorrow, would most parents say, yeah, that's an okay place for the state to intervene? Or would they say, no, that's really something that should be reserved to the parents for them to make their own decisions? So that's basically the harm principle. And it says that only in these cases of significant harm should the state be intervening. That's been expanded a little bit further more recently. This idea of the zone of parental discretion. So the zone of parental discretion actually takes a 2-step approach. So they first of all talk about harm. Is there harm from a parental decision? Is that harm significant? And second, is the intervention worse harm than not intervening? So sure, the state could come intervene and say, you're not reading to your children all the time. And that's not, there is some harm from that. They're not as literate as maybe they'd be if I were reading to them all the time. But the harm of removing that child from a family, removing them from the relationships that are stable would actually be worse than not intervening. And that should be considered as part of the process in making decisions about state intervention. If those 2 criteria are not met, then the idea is that the decision is within the zone of parental discretion, where parents are allowed to make decisions, even if they're not in the best interest of their child, that may be best for other reasons that are not specific to that child. This is a place where legal and ethical obligations actually coincide and are concordant. When the child is placed at risk of harm, there is mandatory reporting. This is also a place where adults and children reporting requirements are fairly concordant. The laws are slightly different, but for most practical purposes, they're quite similar between at-risk adults and children, where if you have a child who is at risk of abuse or a vulnerable adult who is at risk of abuse, those need to be reported by essentially everybody within the healthcare system. And that applies across both those at-risk adults and children. That's a legal obligation and an ethical obligation. There's pretty widespread agreement on this. So just a nice place where we have good overlap between the legal system and ethics. The next area I'm going to talk about is confidentiality considerations when dealing with children. There's 3 areas I want to talk about. The first is familial disclosure. So this is hard to read, but what you're seeing there is actually the birth history form that's sold by the American Academy of Pediatrics to practices across the country, asking about the birth history of new patients to their clinic. And it's hard to see, but some of the questions on there are, during pregnancy, did the mother, some things like take prenatal vitamins, smoke, drink alcohol, use marijuana, use illicit drugs, take other medications? Does the mother have hepatitis B? How about HIV? So all of those are things that are actually medical information about another person. And so there's often lots of maternal information in a baby's chart. How is that protected? So generally speaking, both parents have equal access to the medical records. So the father or second mother, adoptive mother of this baby would have access to the medical record and could actually see all of this information, would have access to information about the mother's substance abuse history and infection history. And so one of the things that's being increasingly recognized, especially in light of the 21st Century Cures Act, open notes, and easier access to the electronic medical record, is what do we do to help protect this information? Should this information be entered into a separate type of encounter, which does sometimes occur at children's? Should this information be prevented from being released to the other parent? And are we collecting the minimal amount of information that's really necessary to care for that child? So some of this information may well be necessary to provide effective care to the child. Certainly, if that child was exposed to opioids in utero, that has absolute implications for that child after they're born and how you take care of them in the NICU. And that's something that you would need to know to care for the child. So there's still a lot of ongoing discussion about how this information should be disclosed, if at all, how a second parent can make effective decisions for their child without access to this information. And so there's a lot of ongoing discussion about this. It's also important to note that these same factors can be true of older children where family history or exposures are documented. So it's not at all uncommon to write in a chart that the child reported that they have easy access to guns at home, or they have easy access to illicit drugs at home, or they were exposed to HIV because they were exposed to their mother and had some kind of shared blood exposure. Those things are all entirely possible to be disclosed in charts, and that may result in unintended consequences for other family members. So it's something to consider as you're choosing what to document in the medical record and whether it's truly important to the child's care, and if so, how it should be documented in a way that's allows the child to be cared for appropriately, but also protects the person whose information is being disclosed. Second area of confidentiality I wanted to talk about is adolescent confidentiality. So in general, adolescents should have an expectation of confidentiality. I think one of the things that's most important about this is that upfront discussions with both the adolescent and the parent who's involved are really important to setting limits on what the limits of confidentiality are and what things would be kept confidential. So having that discussion occurs commonly in adolescent medicine clinics and in primary care clinics where adolescents are seen, where you actually talk to both the parent and the child and you say, I'm going to speak to the patient alone. Anything they tell me, I keep in confidence. I don't talk to the parent about. There are exceptions to that, and those exceptions are generally speaking if somebody is hurting this teenager, if the teenager is threatening to hurt somebody else, or if the teenager is threatening to hurt themselves. In those cases, because those are really big things to deal with on your own, those are things that I would want to talk to your parents about and would talk to your parents about. So those are the common exceptions that are listed when we have those conversations. And having that conversation up front allows everybody to be on the same page. So it allows the parent to say, no, you can't speak to them alone, which at least is transparent, and allows the teenager to know, hey, my parents are going to know about this. It allows the teenager to know, hey, if I talk about one of these things, my parents are going to find out about it. And so there aren't misunderstandings later on about what was confidential and what was not. Laws may differ from state to state in terms of what can be disclosed, as I mentioned before. So again, please check with, if you're outside of Colorado, please check about what must be disclosed and what can be disclosed as you have these conversations. The third confidentiality issue I wanted to talk about goes the other direction. This book is actually not at all about confidentiality, but I like the title, so I put the picture up. Disclosure to minors about their disease can also be a question. So how do you respond to the parent who says, please don't tell my child they have cancer? In general, the ethical principles of honesty and truth-telling would speak against lying to children, so explicitly saying you do not have cancer when you know that that child does in fact have cancer. At the same time, there are often legal requirements that you can't disclose that information against parental wishes. So you can't tell the child if their parent says, don't tell them. So what do? In general, our advice is to decline to answer questions that would require explicit lying. So to say something like, I'm not able to answer that question about why you're in the hospital today, you should really talk to your parents about it, and leave it at that. that prevents the healthcare provider from being put in a potentially professional integrity compromising position of lying to that child without explicitly going against the parental wishes to say what the diagnosis is. Many, especially older children and adolescents, are able to figure out their diagnosis despite all of this. And if that happens, that happens. And I think that in general, we would support encouraging parents to share diagnoses with their child in the most supportive way possible. So providing as many resources for how to have that conversation, offering to be there or not, providing mental health and other psychosocial support resources are always good. There's also some discussion about time-limited lying or time-limited non-disclosure to minors. So for example, a child is in the ED with one parent, they have been diagnosed with leukemia. The parent says, can we please wait for my other parent to arrive prior to telling the child what's wrong? I think most ethicists and most pediatricians would say that's okay, as long as it's for a short period of time and with a clear endpoint and a clear rationale for why that would exist. That's a little bit different than the ongoing non-truth telling to children, which is a little bit more ethically difficult to support. The final area I really wanted to talk about in terms of content is justice and how justice applies to children. We know that there are significant differences across racial groups and across other historically disadvantaged groups in pediatrics, the same as in most other areas of medicine. So on the left here is Colorado gun deaths that are broken down by race. These are all for children over the last about 10 years or so. And these are rates per 100,000 children. And you can see that the rate of non-Hispanic Black children dying from guns is double the rate of non-Hispanic white children and Hispanic and Latino children. So there are significant disparities there between Black children and white children in terms of their rates of death from guns. The same is true for non-traumatic diagnoses. So if you look at national sepsis deaths over the last 10 years, the odds ratio of Black children dying from sepsis is higher. So about 1.4 unadjusted, or even if you account for as many other factors they can come up with, including socioeconomics, insurance status, education level, and a variety of other factors, you still have a significantly higher likelihood of dying of sepsis if you're a Black child than if you're a white child. So we know that these aspects of structural racism exist in pediatrics. There is work to try to undo and to correct many of these, but we certainly aren't there yet. And it's something I think that anybody who is caring for children needs to be aware of. Children's actually just announced this morning a new project to work on maternal and fetal health, which is also wildly disparate between white moms and babies and non-white moms and babies, with non-white moms and babies having significant higher rates of both morbidity and mortality during pregnancy and after birth. I think one of the things that does set children apart is that children often are not able to advocate for themselves. So in general, adults are able to write letters, they're able to call people on the phone, they're able to have some degree of advocacy for themselves. It's not true across the board, but in general, there's a higher degree of self-advocacy for adults than for children. Children generally don't go talk to their legislator. They don't participate in policy decisions. They don't choose which health insurance they have. And so because of that, there's often an underinvestment in children versus adults. The amount of money that's spent on children, as we'll see in the next slide, is quite a bit less than the amount spent on adults. The resources for research for children is often quite a bit less than similarly prevalent diseases for adults. That's why there's more there are advocacy groups for children. The Speak Up for Kids is the American Academy of Pediatrics campaign. There's numerous others that do try to create a voice for the children who would otherwise not have a voice in decision making. The good news, or perhaps the unjust news, depending on your point of view, is that children are cheaper. So there's three different pieces here. The top table shows data from Medicaid for 2019 for per capita spending per enrollee in Medicaid across different groups. So the average across the country is about $8,500 per person is spent by Medicaid. For kids, it's about $3,500. For adults, it's about $6,500. That's non-elderly adults under 65. For the elderly over 65, that's their definition, not mine, just in case anybody's wondering. It's more like $18,000. And for disabled adults, again, defined by Medicaid, that's $21,000. So you can see there's quite a bit of difference in spending. That $3,500 in kids includes kids with disabilities in that category, and similar numbers below that for Colorado specifically. On the lower left, you can see the relative enrollment in Medicaid, which is Medicaid enrolls about 43% children, but the actual Medicaid spending on that population is about half that, so about 20%. So visual representation of that data from above. And then on the lower right, you can see the total average healthcare spending by insurance status. For people under the age of 19, people with insurance spend on average about $2,500. Uninsured people spend about $800, compared to every adult category, including young adults, are significantly higher than that. The only exception for that is uninsured young adults spend slightly less out of pocket. But in general, kids are relatively cheap to take care of. And so when people go asking for money for children whether that's for high-cost drugs or for the child who has significant disabilities and requires more expenditure, just keep in mind that that amount will likely still be a drop in the bucket compared to the amount that we spend on adults. And that's why we have groups speaking up for children. The last area I wanted to consider in the justice section is how children participate in research. And this does happen from time to time at university hospital. There's a few things to think about. First, to protect kids, a lot of drugs have not been tested in children. So there's a lot of off-label use of drugs in pediatrics. Because of that, there's been a push in the last 10 years or so for earlier enrollment of children in trials for new medications, and to go back and do studies in children for medications that were previously approved. And there's been increased funding for some of those studies. And that's something that you may see more and more of, is the inclusion of children in earlier phase clinical trials for new drugs. There are, on the other side, special research protections that do exist for children who participate in clinical research. So those special protections include things like more restriction on the level of harm without benefit that children are allowed to agree to, or that their parents are allowed to agree to. There are particular assent rules for children. So in clinical care, assent is an ethical obligation, but typically not a regulatory or legal obligation. In research, assent is generally speaking a legal obligation or a regulatory obligation for consent to participate in clinical research, especially research that has significant risk to the children. And there's several other regulations that apply, but just to note, there are special protections. As a result of much of this enrollment, many pediatric trial groups are forming to try to create more multi-center sites. One of the difficulties with research in children, especially in research that enrolls children who are not healthy, who have particular diseases, is that there are fewer sick children than there are sick adults. That's both because children are less likely to get sick per capita, and also because the age group for children is significantly smaller than the age group for adults. And because of that, multi-institutional research becomes much more important, and it's much more difficult to conduct single-center trials for any particular new medication for a disease. And that's why many of these multi-institutional collaborative groups exist. Last thing I want to say, and then we'll have about 15 minutes left for questions, which is right on my goal, yay, is just to talk about a couple of the resources that are available out there as you encounter children who have ethical issues. I would put out our Children's Hospital Ethics Consult Service. While we can't do a consult at the U, we are more than happy to talk to you about pediatric ethics literature, about how pediatric ethics thinks about many of these issues, to try to provide a framework and a colleague-to-colleague discussion. As Dr. Glover mentioned, she does work at both institutions, so she's another excellent researcher who does do consults at the university, and it does have better access to medical record and so forth over at the university system. And so she's another excellent resource that crosses the borders between our two institutions. The other big area I wanted to highlight was the American Academy of Pediatrics. You've heard me mention them several times throughout this talk. There's three different kind of bioethics sections that I think are worth knowing about. The first is the AAP section on bioethics. And while there are links here, and I'll try and share these afterwards, honestly, the easiest way to find these, the way I usually find them, is just to type in AAP section on bioethics or AAP committee on bioethics and go to the link. The section on bioethics has a publicly available case-based introduction to pediatric ethics. So that goes through in much more detail a variety of ethical issues that are encountered in pediatric practice. It includes references and readings for each of those areas. So if you have a particular area you're interested in, it's a great resource. If you want kind of a broad-based overview into pediatric ethics more than this talk can give, it's another great resource. The Committee on Bioethics is the group that's responsible for actually writing policy statements and guidelines that are related to ethics in children. So if you're looking for guidance on end-of-life care in children, or consent and assent in children, or research in children, that's going to be the resource you'd want to go to. And they have lots of policy statements and guidelines that you can see that are also publicly available. And then the third thing I wanted to highlight was the journal Pediatrics Ethics Rounds. They call it a casebook, but really what it is a collection of pediatrics ethics cases that have been published in the Pediatrics Journal and that have a case presentation followed by commentary by a variety of both clinical and ethics experts to describe the ethical issues in the case, how they might think through some of those ethical issues, and then a wrap up. So that does require a login through one of the libraries, either the University Hospital Library or the campus library, to be able to get access to. But once you're in there, probably has a ethics case write-up on the topic you're looking for. And it's a great reference to look for those cases that are relevant to your area of practice. So I encourage you to use that as well. In summary, being kids definitely requires different ethical considerations than treating adults. In general, we have parents as the surrogate decision makers, and they're generally, at least for younger children, making decisions without explicit guidance from the patient. Older children and adolescents do gain the capacity to make decisions as they mature. We talked about some of the limits on parental authority and how exactly we should define those limits, which is still disputed. There are different theories for how those limits should be defined. We talked about various confidentiality concerns for babies, for adolescents, for disclosure to children. We talked about the fact that children are affected by structural inequality just as other people are throughout the healthcare system, and that law and ethics don't always align, although when they do, it's great. And with that, I am happy to try and answer questions or other comments, discussion that folks have.
Thank you so much, Brian. Matt, who just said, great talks. Thanks, Brian. Given all the recent issues in the adult world about abortion policy and practice, I wonder if you can speak to how Children's is addressing any challenges you are seeing. Have you been seeing higher volumes of folks coming from out of state, for example?
So Children's Hospital does not provide abortion services because we don't have obstetric services. We do have adolescent gynecology, but not obstetrics. So we haven't been as affected by abortion directly. We certainly have seen increasing numbers. There has been increased interest in contraceptive services for adolescents, and our clinic for transgender youth has also seen an increase in volume, including patients who've explicitly said that they come here from other states where they're not able to get access to the same service for transgender people that they're able to have here in Colorado.
Brian, two common things that people see at the university I would love for you to speak to. One is the never competent adult brought in by the parents. Is it okay to just use the parents? The second one is very young children having babies. And what's the decision making of that 12-year-old, 11-year-old, 13-year-old with her pregnancy and then the birth and then neonate. Can you speak to those two things that are very common, occur at adult hospitals?
Yeah, so the never competent adult patient is something we encounter as well, since we see a fair number of young adults and even older than that adults who have significant cognitive and intellectual disabilities. The ethical answer is that it's probably okay to rely on the parents. The legal answer is no. The legal answer is that they are adults, the same as any other adult, and they require one of two things, either a formal guardianship procedure, Our clinic that cares for kids with complex disabilities at Children's encourages parents to go to court and actually get guardianship established for those patients so that they have legal guardianship, in which case they are the ones who are entitled to make decisions legally on behalf of that patient. In the absence of that, you'd have to go through the same Colorado proxy process you would for any other adult patient. So that means trying to identify the interested parties, which may well be the parents, but may include other people. It may include grandparents, it may include siblings who are adults and so forth, and then asking them to appoint a person. So in practice, the way that works at Children's is we actually do that. We do ask the parents to identify other interested people, ask them to get together and appoint a decision maker who we document in the chart. Almost always that does end up being the parents, but there have been times when that's not the case, where like an adult sibling has been the person who was actually thought to speak best on behalf of their sibling. So that does occur. I think ethically, the person who has the best understanding of that patient's wishes and or the closest relationship would be the person that you would want making those decisions, but that isn't always concordant with the law. The second question about young teenagers or even younger than that delivering children, again, the legal answer would be that those children are able to legally consent for their own care, regardless of age for pregnancy. There is no age restriction on the pregnancy self-consent laws in Colorado. Ethically, it would be a decision-making capacity question. And I suppose that could also be argued even on the legal side, as if that child does not have decision-making capacity to process medical information, apply their values to it, and understand the consequences, they would go through a proxy appointment process. And likely, again, it would be the parents, but they go through a effort to find the person who can best apply that patient's values to the given situation. But generally speaking, the presumption is that those children have the right to make their own decisions.
Thank you. Coming from our spiritual care residents, can you discuss decisions made by parents for a minor based on religious beliefs that others do not perceive to be in the best interest of the child? Great question.
Yeah, so that's a great question. That's actually where a fair amount of that zone of parental discretion and harm principle discussion comes up. That's certainly probably the most common place where that that literature comes up when we're doing ethics consults over at Children's. The first question is, how essential is the treatment that's being refused for religious reasons? How many use blood transfusion? Because that's kind of the common example. So is the blood transfusion truly essential to that child, or are there other alternatives that are available? So are blood sparing procedures, reusing the patient's own blood technologies, are those options for that patient that might be used instead? If that's the case, then absolutely we should choose those and honor those parents' wishes as much as possible. If that's not the case, then generally you are worried that there would be significant harm to the child, then that generally necessitates a report to the Department of Human Services or Child Protection Agency to intervene and say that the parents are unable to consent for the treatment that we think is indicated. There has been work to try to create a process that does not involve going through the Department of Human Services and Child Protective Services, and instead going directly to a judge without having to accuse the parents of neglect, because in general they aren't neglectful. It's a deeply held, honest religious belief. That has been successful in some counties in Colorado, but not all. So that's definitely something that we are still trying to navigate and to try to create a more formalized system across the state to allow that to occur without having to, I guess smear is a strong word, but to target the parents with a neglect allegation.
Yeah. Two other questions from Deb Babson. Can you elaborate on the increase in transgender care from other states? And then Matt wants to discuss the aging out for chronically ill children to adults, the aging out at Children's, and the gap and care in an adult program, and that tug back and forth.
Yeah, so to the first question, I don't really have more data on how many more patients we're seeing. It's anecdotal from discussions with folks who work with our transgender populations. So I don't have good data on that beyond what I've shared. As far as the aging out, that's definitely an issue that we encounter. I think for better or for worse, and I think for mostly better, we've gotten much better at treating a lot of chronic childhood illnesses, whether that's cystic fibrosis, whether that's severe cerebral palsy, whether that's severe hypoxic ischemic injuries to the brain. All of those injuries, we've gotten a lot better at treating and at helping those people to continue to survive, and often with good quality of life. The problem often exists that for a lot of those diseases, there weren't very many, if any, adults really living into adulthood. And so a lot of our adult trained clinicians haven't ever trained how to take care of a 50-year-old with cystic fibrosis. That was just not something that existed at the time that many adult pulmonologists trained. And so there's a lot of work in how do we transition those folks to adult facilities where they'd likely get care that's more concordant with their age. I vividly remember a patient with one of those childhood diseases who was getting divorced and was asking for questions about how they manage custody of their children. And I said, I'm a pediatrician. I know how to help the children with that. I don't know how to help you with that. So I think that kind of care would be much better provided at adult hospital. But it's a big lift to help our adult colleagues learn those diseases and how we manage them in a way that might be new or different from what they learned in training. One of the places that's been really helpful for that is some of the medical pediatrics training, so the combined residencies between medicine and pediatrics. And a lot of folks who do that residency end up practicing in that liminal space, that space between medicine and pediatrics, and help to transition those kids and now young adults from pediatric care to adult care. And there have been some successful programs that do that very well. I think probably the best example is the congenital heart disease program, where there's an explicit transition to the adult congenital heart disease program as those children become adults and can be cared for at the university.
And a point of clarification from JB, Children's does provide obstetrical services to patients who do require MFM, maternal fetal.
That's true. Yes, sorry, that is absolutely true.
And the U and Children's share the Colorado Fetal Center.
Thank you. Yes, that's completely true.
Okay. Organ transplants. If a child has received an organ transplant at Children's and now needs to be retransplanted, but now is in an adult hospital, should the now adult be placed at the top of the transplant list?
So that's a really good question that we don't have a good answer to. I really don't have a great answer to that. We do, in general, consider previous transplant status when making transplant decisions, mostly because there are ties between previous transplant status and likelihood of future transplant success, and that's an ethically relevant feature in making that determination. I don't have a great answer for how that person should be determined when they change, how that status should be determined when they change institutions.
Great. I'm one of those, Erin Manning, great. I'm one of those MedPeds providers. We'll actually be rolling out a MedPeds consult service, in January, where MedPeds trained providers will be able to consult on adolescents and young adults with chronic conditions of childhood hospitalized at the U. Erin, thank you so much for that information. Hot off the press.
Yeah.
If there's no other questions, I would like to thank Dr. Jackson for an excellent presentation. Remind you of the sister or brother or non-gendered partner presentation about taking care of adults in pediatrics. More information to follow. And in October 13th, the next ethics grand rounds will be October 13th on the topic of capacity assessments for not medical interventions, but for discharge. And we're designing a new pathway and new documentation. And Emily McDowell, who has been our guardian social worker, will unveil the ethical issues with this population of patients and a new exciting tool for assessing capacity, not only for medical interventions, but for discharge decisions. So Thank you very much, Dr. Jackson, and everyone for attending. And this will be posted on the Center for Bioethics and Humanities website at coloradobioethics.org under Clinical Ethics, Ethics Grand Rounds. See you in October.
Thanks for having me.